Hi, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha. I am a nurse here at UWorld. I'm so excited to see you all here today. Today we're going to be diving into some common psychiatric disorders, being anxiety, depression, and lastly, schizophrenia. So many of you watching today may know someone who's suffered from one of these or may suffer from one yourself. Mental health is a huge issue here in the US, making it a very worthwhile study topic. Even if you're not interested in psychiatric nursing, I can promise you, you will encounter clients with mental health issues in every single clinical area of the hospital or of the clinic wherever you plan to work. And of course, you will see mental health questions on your NCLEX. So with that being said, before we get started, a couple of reminders for you guys. If you haven't already, follow us at UWorld Nursing for all things nursing social so you don't miss out on any resources, any live lecture sessions like today, or any future question drills. Keep also letting us know what topics you want to see us cover. We've had a lot of requests for pediatric and OB content lately, and we've really hit that hard in the past few weeks. We're hitting mental health today, which we also get a lot of requests for. But if there's another topic that you want to see us present, please let us know. We are here to help you, so let us know the best way we can do that. I hope that we're meeting your needs. And also, we will be this will be live on demand on our social channels after we're done. So if we went through something too quickly or you want clarification, you can go to any of our social channels and this live will be reposted onto it. I personally find YouTube the easiest one to search, and you can search all of our repository for all of our past lives for that as well. So drop your comments and your questions in the chat as we move along today. Nurse Jackie is moderating, and let's get that chat started by letting us know where everyone is joining us from. Who is an international viewer, who is joining us from the US, let us know. I see lots of people in the chat. I see someone from Johannesburg, South Africa. So welcome, we are so happy to have you all here. I'm also going to open the chat up with another content-based question as we dive into today's lecture material. So before we jump into our anxiety image, let me know in the chat, what are some clinical features of general anxiety disorder? So what does a client with generalized anxiety look like in a clinical setting? Go ahead and drop those in there. What are our signs and symptoms, our manifestations, whatever you want to call it, of generalized anxiety disorder? And I'm going to jump right into our patho behind anxiety. So let's start off by discerning between what a normal level of anxiety is and what qualifies as generalized anxiety disorder. So anxiety is something that we all experienced. I'm sure that if you are in nursing school, before you take a test or perform a new skill in your clinical, or especially before you take your NCLEX, you have experienced anxiety. So anxiety related to these type of stressors in life is totally normal when the anxiety is proportionally related to the stressor and when the anxiety resolves after the situation or activity is completed. The difference between normal anxiety and generalized anxiety disorder is that in generalized anxiety disorder, or GAD, the worry and anxiety is excessive. It goes above and beyond what the situation demands. And this anxiety isn't limited to just one situation. It can encompass all aspects of life, from work, school, family, children, whatever, friends and family even. The amount of worry that these clients experience is frequent, meaning it's happening most days of the week. And generalized anxiety is also going to come along with those physical symptoms that I ask you guys to drop in the chat, some of which include being queasy, being faint, having a headache, a racing heart rate or tachycardia, heavy breathing, rapid breathing, sweating, and I see almost all of those dropped into the chat. Diaphoresis, so true, sweating, agitation, tremors, tachycardia. You guys are totally spot on. So this anxiety is going to spill over into the client's responsibilities. It might impact how they interact with their family, how they function at work, and their overall health in general. So in terms of risk factors, there isn't a specific cause that's linked to generalized anxiety disorder, but it could be a combination of genetic, psychological, and developmental factors, as experts believe. So now diving a little deeper into our manifestations, our client with generalized anxiety disorder will be in a constant state of fight or flight. And this is what causes those symptoms. So that fight or flight state causes difficulty concentrating. The clients will feel very on edge, very agitated in some cases. And think about tense. They're very tense. They have a tense heart. So we see tachycardia, or that increased heart rate. Tense muscles. So think when your shoulders are all the way up almost by your ears. And think a tense mind, which leads to difficulty concentrating, difficulty falling asleep at night. Alrighty, so nursing interventions, what can we do as nurses to help these clients? For all three of our different disorders, we're going to have a theme, and our theme for nursing interventions for anxiety is going to be stay and calm. And this means that we need to stay with the client and keep them calm. Instruct them to take slow, deep breaths, to slow down, to try and relax a little bit. Other nursing interventions include, of course, our pharmacological interventions like benzodiazepines and SSRIs, or selective serotonin reuptake inhibitors. These are commonly used to treat anxiety. And if an acute anxiety attack is taking place, we would give a quick-acting med instead. We can also see cognitive behavior therapy, or CBT, to help prevent these episodes of anxiety, whether it's an anxiety attack or generalized anxiety, from happening. And what this does is it helps the client to identify what provokes their anxiety and identify it before the panic attack happens. Or the anxiety attack, excuse me. Then we want to instruct the client to challenge these thoughts and replace them with something more realistic. So I'm going to use public speaking as an example because I know a lot of people are really fearful of public speaking. It's not everyone's cup of tea. So it would go something like this. The client might say to the therapist, "I'm going to mess up, and everyone is going to think that I don't know what I'm talking about." Over time and with practice with CBT, the client can reframe this feeling or reframe this thought to be something more along the lines of, "I have prepared the best I can, and I know this information like the back of my hand." Other things we can do are to encourage stress reduction techniques like journaling, exercising, or any hobby that the client enjoys, maybe tennis, maybe mahjong, something fun. Alrighty, so that concludes anxiety. We're now going to move on to major depressive disorder. So drop in the chat what some clinical features of major depressive disorder will be. What will a client with depression, with major depressive disorder, look like? How will they present clinically? Alrighty, so I'm going to jump right in as you guys answer this. So diagnosis, let's talk about what leads to a diagnosis of major depressive disorder. So we can define major depressive disorder as persistent, meaning it's more than 2 weeks of a change in mood, of feeling down, feeling sad, or having a general loss of interest in daily activities and activities that the clients used to enjoy. So knowing that, let's talk about what happens in our brain that can lead to depression. So clients with depression often have a deficiency in neurotransmitters in their brain, specifically the ones that are responsible for mood, thoughts, and behavior, and demonstrate a significant impairment in daily functioning. So these neurotransmitters include serotonin, which controls a lot of mood, norepinephrine, which helps us to take action in fight or flight. It's like an activator for our body. And lastly, dopamine, which is responsible for pleasure and the pleasure centers of our brain. So there are a couple risk factors for depression. Genetics play a really large role in depression and the proclivity to have depression in your lifetime. A family history of depression, of course, increases the risk for a client to develop it on their own. Stressful life events can also lead to major depressive disorder. So maybe someone has lost their job, they get laid off, they go through a relationship change like a divorce. Substance use is another one that can bring on depression. If a client goes from taking a substance and getting a high from it, and then they crash back down to baseline, it can elicit a depressive mood and cause them to go down the road of further prolonged substance use. Grief or loss can also provoke depression, especially if it's unresolved grief or an unanticipated loss. Medical conditions and medical diagnoses can also lead to depression, especially with certain chronic diseases like Parkinson's or MS, or a terminal diagnosis, something like metastatic cancer. And the last risk factor is being sedentary increases your risk for depression. When we exercise, the body releases endorphins, which make us happy. If you watch Legally Blonde, they talk about that. So when we're not moving and we're not releasing endorphins, this also increases our risk of developing depression. So a lot here. I see someone say postpartum. There is postpartum depression, absolutely. That is a life change. We cover that in one of our maternal health lives. I see too much or too little sleep. You guys totally got it. Way to go. So we covered patho and risk factors. Let's move on to manifestations. I think this is what some of you guys were kind of getting to in the chat. So depression can affect clients of all ages, of all races. It can affect children, it can affect older adults, but it's important to recognize it's not a one-size-fits-all for age groups here. And also important to note for our aging populations, depression should not be treated as a normal part of aging. It is atypical. When we're caring for older adults and we see them being depressed, this is not expected. This is an outlier. It requires intervention and it requires follow-up. So starting at the top of our body, we'll work our way down. We'll start with our body and our mind. So we can see manifestations of depression as sleep disturbances. Either this can be sleeping too much or sleeping too little. Clients can have feelings of guilt and worthlessness. They can see trouble concentrating and just being very generally forgetful. And we can also see a lack of interest in activities that these clients once used to enjoy. Weight changes are also really common with depression. So a lot of this results around not wanting to get up and prepare a meal, not wanting to get up and move. And this can manifest either way. We can see clients that don't want to get up, they just sit and eat more than they typically would and they gain weight. Or we see clients that don't want to get up and prepare meals, therefore they don't eat and they actually lose weight. And we can, of course, see suicidal thoughts and behaviors in severe cases. We're going to talk a little bit about this later, how we keep clients safe if they express these feelings and they bring up suicidal ideation. But we must know that any mention of suicidal or homicidal ideation is an emergency, a priority, and something we need to act quickly and act thoroughly on to make sure we keep these clients safe. So one thing to note before we move on is that depression, when we diagnose it, we want to rule out other conditions like hypothyroidism that can result in similar manifestations. We need to rule these out first before we diagnose officially as MDD or major depressive disorder. Alrighty, so I have another question to put out to the chat. What medications do we commonly use to treat major depressive disorder? Drop it in the chat. Let me know if you just want to use the acronym. That's totally fine. I don't blame you. Some of these names are pretty long. But what medications do we commonly use to treat major depressive disorder? All right, I see we already have one in here. I see SSRI. That's totally correct. Selective serotonin reuptake inhibitors. And I want to see one more I'm looking for. It's very similar to SSRI. But we also see SNRIs, which are selective norepinephrine reuptake inhibitors. So SSRI and SNRIs are some of the most common ones that I was looking for. So common meds include, of course, those SSRIs and SNRIs. But what else do we do to manage depression? So one of the things we're going to mention a lot is our priority for depression is safety. So with anxiety, our theme there was stay and calm, stay with the client and keep them calm. With depression, our major theme here is safety. So especially if this client has those suicidal or homicidal ideations, as a nurse, we have to be able to ask those tough questions and assess for any of this SI. If the client says, yes, they are indeed having thoughts of suicide, they need to have a one-to-one surveillance. They may be an in-person sitter, it may be a virtual sitter, regardless of the location the client is in. We also have to make sure the environment is safe. So we're removing anything sharp the client could use to injure themselves. We're also removing anything that's a hanging wrist that could be used for ligature. So any material that's not breakaway material, we would also want to remove. And if they're home, we need to make sure that we identify if there are any weapons in the home and we remove them from the home. We need this client to develop a safety plan. So in case that they do have suicidal ideations when they are not in the hospital, they know what to do. And this will include knowing who to call if they need help, and most importantly, where they need to go. Where is the closest ER? Where is the closest provider of mental and medical help? For therapy, we follow a lot of the same principles as with anxiety, and we can again use that CBT or cognitive behavioral therapy to change some of this negative thinking, reframe our thought process, and implement more positive coping mechanisms. We also want to encourage these clients to get out of the house and participate in helpful support groups. We want to encourage exercise and relaxation techniques and offer them positive reinforcement as they progress in these therapies. I see someone say, not to be left alone. You are absolutely correct. Way to go. I also want to explore another intervention called ECT, or electroconvulsive therapy. So this is used for treatment of depression, and it's most commonly used in clients with treatment-resistant depression, or also it can be used in bipolar disorder. So when traditional therapies and medications have failed, ECT may be the next best option. So essentially what happens in ECT is the client is connected to a machine that delivers an electrical current through a targeted area of their brain. So in simplified terms, we're simulating a mini seizure in the brain. It's a brief tonic-clonic seizure, and while all this is happening, the client is connected to an EEG monitoring system. An EEG is kind of like the ECG is to the heart, as what the EEG is to the brain. It's just a way to continuously monitor. After treatment, some clients may experience adverse effects and side effects similar to a client who's in the post-ictal phase of a seizure, and this can look like short-term memory loss, typically returning within a few hours. Clients can be nauseous, have a little bit of vomiting, maybe there's an episode of emesis. They can also experience headache, confusion, and a little bit of disorientation. Alrighty. So I'm going to move on to our final section of the day, and this is schizophrenia. I think this is our most complex subject matter today. This is a very complicated disorder, but I'm excited to go over it with you guys in depth. So schizophrenia happens when the client essentially is unable to interpret or interact with reality normally. So think about their outward expression being abnormal, as well as their inward interpretation also being abnormal. And this together is going to cause abnormal emotional responses, So the causes or risk factors of schizophrenia are largely unknown, but we can pin it to a kind of a cosm of different factors like environmental, genetic, as well as brain chemistry. And this leads us right into our manifestation. So we have a great schizophrenia slide here. It goes over our positive and our negative symptoms, but let's go a little bit more into the etiology of this before we divide positive from negative symptoms. So when I said brain chemistry, what I was referring to is the neurotransmitter dopamine. So dopamine, we talked about it a little bit earlier. It's responsible for that reward, that pleasure center, feelings of joy, motivation, satisfaction. It also is responsible for movement. We talk a lot about dopamine in our Parkinson's live review. So if you at all want to go back into this, there's a really great explanation in that video. Go to any of our social channels, or if you want to search in our YouTube, I think that's the easiest way to get there, and look up our Parkinson's lecture video. But essentially, clients who have too much of this circulating dopamine are going to exhibit positive symptoms. When we say positive, we mean extra or something on top of baseline. Now, these extra symptoms include a couple of things. So we have hallucinations, and it's important to differentiate between hallucinations and delusions. They're easy to get confused. So a hallucination is going to be based on the senses. So it's going to be auditory, something we hear, visual, something we see, tactile, something we touch, or olfactory, something that we smell. Delusions are different because delusions are going to be based on beliefs and ideas that this client holds. Other positive symptoms include disorganized thoughts and speech. Examples of this are loose associations. One thing we can see here is if someone said, "I like when I see carrots," "orange trees are big," "sunshine is my favorite." Now, this doesn't really make sense back to back, but they're all loosely associated. Carrots are orange, orange is the color of sunshine. Even though it doesn't make sense to a normal person interacting and conversing normally, it's loosely associated for a client who has schizophrenia. Neologisms just mean making up new words that are not a part of the English vernacular or whatever language the client speaks. Tangentiality means a client that goes off on tangents. So this client repeatedly diverts from the topic at hand, and they cannot be brought back into focus on the topic at hand. Word salad is another positive symptom that we can see. This could be something like green, butter, day, singing, December. This is different from loose associations because there's no common tie between these words. It's just a salad of different things being thrown in. And lastly, we have echolalia, which is just a client who is repeating things that they hear, what other people are saying, not having any unique thought. They're just repeating what they hear, kind of parroting it. We also see disorganized behaviors as positive symptoms. An example of this is catatonia, or a catatonic state. In this state, clients are unresponsive. It's a sleep-like state. They may be sitting or standing in an uncomfortable or strange position. Again, remember that dopamine also is responsible for movements. And with that being said, we can see crazy, abnormal movements in these clients, like a jerking, twitching, or abnormal function from regular motor function. Alrighty, so let's go ahead and drop to our negative symptoms. We'll move to the other side of the spectrum. So clients who have too little circulating dopamine will exhibit negative symptoms. Now, it's the same idea as those positive symptoms being extras. The negative symptoms are like deficits, so we're taking something away. Examples of this include apathy, which is a lack of motivation in activities of daily living. Hygiene is a really big one here. They can be asocial, which means they're socially withdrawn, not interested in conversing with others. Affective flattening, which is just a flat affect, an emotional response. So if you talk to them, they show no emotion, they're very curt, they're very brief. We can see anhedonia, which means the inability to experience pleasure. Maybe the client used to love to play tennis and now they take no joy in that whatsoever. Alogia means a poverty or lack of speech or thought, just they're not really thinking a lot. They're kind of, again, just not having that flat affect, not really interacting. Alrighty, so let me know, drop in the chat, what's something new you've learned about schizophrenia so far? I feel like the etiology here, the manifestations and the patho is pretty complex. So let me know, what did you learn? Was it a positive symptom? Was it a negative symptom? Was it something about the risk factors for schizophrenia? Let me know something new that you learned today. Alrighty, I'm gonna go ahead as you guys let us know. We're going to move down to our nursing intervention. So remember when I talked in anxiety and major depressive disorder about themes for all of these different sections? So anxiety, our theme was stay and calm, stay with the client, keep them calm. In depression, it was safety, keep the client safe. In schizophrenia, our theme is going to be trust. So as nurses, we build trust with these clients through frequent, short interactions. We avoid touching the client because we want to make sure we set and maintain their boundaries. And we want to be neutral in how we approach the client. So again, think about these clients falling so heavily into the positive or negative symptoms on the ends of the emotional spectrum. So they're really high, really low. We want to meet them right in the middle, stay very neutral. If we're performing an intervention on the client, we make sure we explain the procedure step by step. We're trying to give them small bits of information at a time without overwhelming them. And we also want to start them into activities one-to-one instead of incorporating right into a small group or a larger group therapy setting. We want to start out one-to-one, take those baby steps. Alrighty, I see someone said I want to know the difference between positive and negative, please. Remember, positive symptoms are an extra, there's something above baseline. Negative is a deficit, something below baseline. Positive means we have too much circulating dopamine, and then negative means we have too little circulating dopamine. Alrighty, so a couple really key important things for our nursing interventions for schizophrenia. We talked a little earlier about hallucinations and delusions. Managing them is going to be a key part of our nursing intervention. So let's start with hallucinations. We need to understand more about what's triggering these hallucinations in order to intervene. So we need to ask direct and clear questions about them. So we would say, tell me more about what you're seeing. What are you hearing right now? What do you smell right now? We want to prevent an escalation of emotion from these clients, and we want to monitor for heightened anxiety and agitation and make sure we're decreasing stimuli around the client. So this can look like removing them from an overwhelming situation, or maybe providing them with a distraction. Headphones or noise-canceling headphones can help. We can also give them a small structured activity like folding a napkin or something simple like that to keep their brain focused on a task so they don't get overwhelmed. You only want to speak about reality, so you never want to dive and entertain into that hallucination with the client. You need to ground them back in reality. So a patient who reports seeing spiders on the ceiling may ask you if you see them too. A good response would be to say, no, I don't see spiders on the ceiling. What I do see are ceiling tiles, a fan, lights, and an alarm box. This grounds them in reality, but it doesn't state, you're wrong, there are no spiders on the ceiling. That's not what we want to do. Simply that you yourself do not see what they're seeing. We also want to assess our clients for thoughts of harming themselves or others, especially if they're experiencing command hallucinations. Now, what command hallucinations are hallucinations that lead them to believe they're being told to perform a specific action or intervention. Alrighty, now we're going to go ahead and jump to managing delusions. So switching gears from hallucinations, which again are based in senses, to delusions, which are false beliefs or ideas. So this is going to include a lot of active listening. So saying back some of the things that you're hearing, showing empathy and sharing or relating to these clients. So you don't want to argue with these clients about their delusions. You don't want to tell them, you're wrong, that's not true, that's false. It's the same idea as with hallucinations. We want to try and ground the client in reality. So we might want to try and change the topic of conversation. clients who are experiencing delusions are pretty suspicious of anyone around them. We want to make sure we take the opportunity, but we don't lead to more delusions coming out. And remember, think back to our theme, trust. So this can look like offering clients as canned or pre-packaged foods, seeing and showing them that essentially this has not been tampered with. There is no way that anyone was trying to harm you, poison you, or put something else in this. We also want to open medications right in front of them, and this is the same principle as prior. We don't want to make them think we're sabotaging them or we're giving them something that they didn't agree to. After they take their medication, we want to make sure we check their mouth, their palms, maybe their pockets to make sure they actually took the medication and they're not stockpiling it for an overdose later or to harm anyone else. So that sums up interventions for our positive symptoms. Let's switch gear to our negative symptoms. Again, negative symptoms are our deficit symptoms. So interventions here, nursing interventions for the negative symptoms of schizophrenia might include things like social skills training. So giving them the tools they need to interact and engage socially when they're showing signs of readiness to do so. We also want to make sure we're helping them with activities of daily living, meeting their basic needs, especially if they can't meet them themselves. A big one here is going to be hygiene and dressing themselves. And as with anything, encourage them with positive reinforcement along their treatment journey. This is all about the baby steps. Alrighty, I see someone say avoid whispering to another nurse in front of them. This is totally correct. Way to go, Stella. So we're now going to move on to our first question of the day. So this is a question about major can't hear me, we are working on that right now. Alrighty, let us know if you're able. Oh, now I think YouTube is the same as well. We are working on that. Go ahead, drop those answers in the chat. Thank you for bearing with us. Alrighty, I'll give you a few more seconds. If you can't hear, go ahead and read it on the slide and just drop the answer in the chat. Okay, I see someone saying it's back. Now we can on Instagram. Now it's good. Okay, good, good. Thank you for sticking with me. So again, drop those answers in the chat, 1, 2, 3, or 4. Let me know what you're thinking. And in the meantime, we have kept up very closely with our NCLEX passing rates. And interesting enough, we've seen an increase in passing rates after the implementation of that next-gen NCLEX in April of 2023. We've had very high passing rates, but now as of Q4 of 2024, so those last 3 months of 2024, we've seen them go back down to closer to what they were before we initiated the next-gen NCLEX. So really important with these pass rates falling, that bell curve coming down, you need to make sure you are adequately preparing for your UWorld or for your NCLEX. You are studying, and UWorld can help you do that. We have helped over 1.2 million students prepare for professional nursing exams. Of those students, those that score an average of 70 or above on our QBank enjoy a 98% NCLEX pass rate. So I know that people saw the pass rates were so high in the past few years. They made it feel like, oh, I don't need to study that hard. I don't need to do a testing platform. I don't need to get a QBank. But in reality, these passing rates are going back down. Make sure you are prepared, and UWorld can help you do that. And if you want more information, go ahead and check out uworldnursing.com. Alrighty, I'm so glad you can hear me now. Thank you for bearing with us. And I'm gonna go ahead and reveal our correct option. I see almost all correct options, which is number 1. I will help you get ready, then we can walk to the dining room together. So the client with major depressive disorder needs a little structure and direction in performing these activities of daily living, or ADLs. Just waiting for the client to become more energetic and initiate activity and interaction on their own is not going to be helpful, because they're probably not going to do it. By saying I'll help you get ready. We can walk together. We're assisting them in their ADLs. We're providing a sense of caring. We're providing them an opportunity for interaction with the nurse. And this also all together will help to raise the client's self-esteem. So option 2, I will have breakfast brought to your room. I know you don't have much energy right now. This is kind of brushing on the idea of they don't have much energy right now. If you have MDD or major depressive disorder, they're probably also not going to have much energy later. So we're kind of just putting off what needs to be done. Option 3, it is okay. You can join us when you're ready. Take your time. Again, just waiting for them to have some sudden burst of motivation or energy is not really going to be an appropriate intervention because it's probably not going to happen. And lastly, 4, you will feel better when you get up and get dressed. You need to eat something. This one is not necessarily therapeutic communication. This is a little bit tough, a little bit too intense. So again, option 1 was our correct option. Alrighty, question number 2. So now we have a schizophrenia question at hand. So the nurse is assessing a client with schizophrenia. Which of the following findings would the nurse expect to observe? Select all that apply. Our options are apathy, 2, social withdrawal, 3, agitation, 4, ritualistic behaviors, 5, anhedonia, or 6, disorganized thought content. Alrighty, select all that apply. So we have more than one correct option. Go ahead and drop those answers in the chat. In the meantime, UWorld is partnered with NSNA, the National Student Nurses Association. We are so excited about this partnership. We are the official test prep provider for the NSNA, I believe for like the next 3 years. So we're excited about our partnership. If you're not a member of the NSNA, there is no time like the present to join. Through NSNA, UWorld will be offering virtual sessions throughout the year, as well as a really big appearance and NCLEX review session at their yearly conferences. We'll be there in Seattle in April, as well as in Columbus in November, I believe, putting on NCLEX review sessions, focus sessions, games. We'll have a booth there, lots of fun stuff. So if you're not a member of NSNA, think about joining. It's a great organization, and we're so excited to be partnered with them. Also, just to cue you in for this week, we will be covering pediatric question drills tomorrow on Wednesday at 2 and 3 p.m. Central Time, and we'll be back on Thursday with most missed question drills. I'll be going live at 11 a.m. Thursday, and then my friend Nurse Coley will be going live at 3 p.m. Central Standard Time with, again, most missed questions. Alrighty, I see lots of answers in the chat, and I'll give you a hint. We had lots of correct options out of 6. Only 1 was incorrect. I'll give you that hint. But our correct options, it looks like most of you guys got the bulk of it. You maybe just missed out on 1 or 2. So 1, 2, 3, 5, and 6 were our correct options. So everything except for 4. So remember, clients with schizophrenia may experience positive or negative symptoms during the active phase of this disorder. And this is determined by if they have too much circulating dopamine, which results in positive symptoms, or too little circulating dopamine, which results in negative symptoms. So the negative symptoms that we see here are apathy, social withdrawal, and the anhedonia. Apathy is lack of, this client doesn't really care much, they're not very involved, they probably have a pretty flat affect. Social withdrawal just means that they are not willing to socialize or converse with their peers. Anhedonia means a loss of pleasure in activities that the client once enjoyed. Our positive symptoms are going to be agitation, which I'm sure you all know what that means, and disorganized thought content, which is just kind of a disorganized way of thinking. We talked about a lot of those tangentiality and loose associations and word salad that we can also see, but those would be our positive symptoms. So again, everything but option 4. Option 4 was a ritualistic behavior or a compulsion, and this is more along the lines of being characteristic of OCD or obsessive compulsive disorder. Alrighty, again, 1, 2, 3, 5, and 6 were our correct options there. Alrighty, so we're going to jump to a QBank image for all of our viewers that are already on UWorld. Here is a look at the subjects and the systems to select to get more mental health concept questions so you can practice what you learned here today. Go ahead and challenge yourself and test your knowledge. And in closing, visit uworldnursing.com for all things UWorld Nursing Social. Make sure you check out all of our lives on demand on whatever social channel you prefer. I think YouTube is the easiest one to search. But thank you guys for staying tuned. I hope that you find this to be helpful. We're going to be going live again tomorrow at 2 and 3 p.m. Central Standard Times with Nurse Jackie for a pediatric question drill, and I hope to see you guys there. Bye.